things are going.
Can you call out the names of the students to see whether they are available or not?
Hi, Rupa.
Good
Hi,
evening,
ma'am.
Jayanti
How are
ma'am.
you? Good evening. Good evening.
Just remember, it is not IBD ENC, okay?
Dr. Kushan from Apollo, is he there?
Yes, good evening, sir. I'm there, sir.
Dr. Praveen from KIMS.
Yes, sir. I'm here, sir.
Dr. Karthik from Apollo.
Yes, sir. Good evening, sir.
Dr. Joe.
Yes, sir.
Rohan from SIMS.
Good evening, sir. I'm there, sir.
Snija.
Yes, sir. I'm here, sir.
Okay. So all are there.
Remember the names?
Beg your pardon?
How will we remember the names?
I'll just send it to you. The thing is, they'll be having turns. So we'll start with Kushan, and then
Yes,
I have actually broken down this thing into 4 parts. So Kushan, Praveen, Karthik, and Rohan, and then followed by Joe and Snija. Rupa, when you present your case, you can ask the first set of questions to Joe and the next set of questions to Dr. Snija.
Yeah, I'm very poor at asking questions. Joe and Snija, don't worry. I'm very soft-hearted that way, so you can just do the best that you can.
Okay, can we start?
Yes.
Good evening, everybody. Welcome to this edition of ISC Kerala PG Clinics. Today we have with us Dr. G.N. Ramesh, who is well known to you, a senior faculty from Aston Med City. He is the head of the Department of Gastroenterology at Aston Med City, Kochi. And you have seen Dr. G.N. Ramesh in almost all activity of ISC Kerala as well as the national body. Along with Dr. G.N. Ramesh, we have a great person, Dr. Rupa Banerjee, who is synonymous with IBD in India. Okay. Earlier, Asian Institute was famous for endoscopy, and we used to call Mecca of endoscopy. Now, Dr. Rupa, after joining, has given a different perspective to AIG, not only endoscopy, but in inflammatory bowel disease. So, Asian Institute has become another Mecca for IBD as well in India. And under her initiative, so many activities are going on. And Dr. Rupa is a senior consultant in Asian Institute of Gastroenterology and head of the IBD division. She is also a faculty of the Basic Science division of the AIG. Another interest is NBA. Before I think started in a big way in IBD, Dr. Rupa was the NBA person of India. Okay, so she is well known in so many ways, and she has so many publications to her credit. And I welcome both of you to today's clinic, and I welcome all the other senior faculties as well. And I welcome the discussants, Dr. Kushan, Dr. Praveen, Dr. Karthik, Dr. Joe, Dr. Rohan, and Dr. Snija. So with these words, I hand over the mic to Dr. G.N. Ramesh to conduct today's class.
Thank you very much.
I will stop sharing.
Much, Dr. Varghese. It's a pleasure, and Rupa, welcome once again. Okay, now the format is going to be the same. So, okay. Now, can you see this, my slides?
Yeah, visible, well visible.
I would. Okay, so basically the theme today is inflammatory bowel disease, and we'll be going through most of the facets of inflammatory bowel disease in the next 1.5 hours. I would first of all like to request Dr. Kushan Sengupta,
Yes.
no, from Apollo.
Yes, sir.
Apollo,
Yes, sir. Good evening, sir.
Which
Sir, Apollo Chennai, sir. Apollo Chennai, sir.
Okay.
Good evening, sir. Good evening, ma'am.
You're comfortable?
Yes, sir. Yes, sir.
You appear to be a bit ruffled, unruffled. Your hair is a little bit. So anyway, so this is the case that we start off with, and
Yes, sir.
it's basically a 54-year-old female with no significant past history, presents with a
Yes, sir.
3-month history of rectal bleeding, tenesmus, and obstipation. You know what is obstipation? What is constipation?
So the inability to pass stools and flatus both is obstipation, sir.
Okay. And the symptoms started after a brief febrile illness. There's no weight loss, has occasional nocturnal symptoms of urgency and occasional pain, lower abdomen, no other comorbidities. 1 to 2 formed bowel movements daily with mucoid discharge and blood staining of stools till about 1 day back. There are no systemic symptoms, no abdominal pain, no weight loss. She had undergone a colonoscopy at the age of 50 for altered bowel habits, but at that time she did not have any bleeding. There are no history of NSAID use. The labs were normal. I would like to ask you, first of all, Kushan, any other information that you would like to have? Any other questions that you would like to ask? And
Yes,
you also have to tell me, why do you want to ask those questions?
Yes, sir. Sir, the patient has a rectal bleeding and tenesmus for 3 months, sir. Sir, I would like to know what is the frequency with which she is passing the stool, sir, and what was the frequency before the onset of symptoms, sir?
Yeah, I said 1 to 2 formed bowel movements daily with mucoid discharge and blood staining of stools. The frequency has not increased by much. Before that, it was once or maybe less than that, but now it is 1 to 2. Are you happy?
Yes, sir.
Anything else?
Sir, is there any associated fever or abdominal distension because the patient also has obstipation, sir?
I mentioned no systemic symptoms, no abdominal pain, no weight loss.
Okay, sir.
Why do you want to ask that?
Sir, because the patient had obstipation, so I wanted to, and the patient also has this rectal bleed and tenesmus, so I wanted to ask for if there is a underlying ulcerative colitis with toxic megacolon that could lead to obstipation, and in that case, there will be abdominal distension, sir.
Okay. Anything else that you want to ask?
Sir, any extra intestinal manifestations like skin rash or joint pain, back pain?
There are none.
All right, sir.
Have you confirmed or have you zeroed in onto a diagnosis of inflammatory bowel disease?
Sir, no, sir. I mean, there could be other possibilities also that I would like to consider, but
Your questions,
IBD
all
is
of
one
them
of
seem
the.
to be tailored towards, because today's panel discussion, today's theme is inflammatory bowel disease. So you're talking of only inflammatory bowel disease. With this sort of history, would you like to consider any other possibilities?
Yes, sir. Sir, the first possibility I would consider inflammatory bowel disease, in which I will consider ulcerative colitis, and after that Crohn's colitis, sir. The second possibility that I would consider is since the age, she is more than 50 and also a short duration of history, so I would also consider a malignancy in the rectosigmoid area, sir. And probably if she is going into complete obstruction, in that case, the
Anything
patient
else?
may have obstipation, sir.
Okay. Any other thing that you would like to ask? Or any other differential diagnosis that you would like to consider?
Sir, then the third could be infective, like a CMV colitis, sir.
But do you see primary CMV colitis like that?
Ma'am, a little unusual, ma'am. It's generally not seen, ma'am. Other infective diseases could be like Clostridium difficile infection, but again, ma'am, the presentation with rectal bleed is a little unusual in those patients, ma'am.
What did you say? Clostridium difficile?
Yes, sir. But sir, they generally don't present with rectal bleed and tenesmus, sir.
What is the usual setting for a C. diff infection? And what is the presentation usually?
Yes, sir. So most of the patients are old age patients, and they are bedridden patients, and many of them are immunocompromised, sir, and they present with increased frequency of stools.
Does this patient have any of the features?
No, sir. This patient does not have, sir.
Yes, Dr. Rupa, you're asking something?
Said that if you're talking of Clostridium difficile, there will be a definite, I mean, the commonest will be some history of other antibiotic usage or anything like that, which is not
Yes, sir. Yes,
there
is not
here.
there.
So I think we have to be reasonable in our differential diagnosis as
Right.
well.
Right. So
anything else that you would like to consider? Okay, a 54-year-old lady who is presenting with a short history of lower abdominal pain and altered bowel habits with mucoid discharge, occasional blood stained, and has a constipation. Anything else that you would like to consider?
What about, would you like to ask about a possibility of a sexually transmitted disease?
Yes, ma'am.
Okay, I'll ask you now. You have fallen into a trap. What sexually transmitted disease are you considering, and what would you ask?
Sir, sexually transmitted disease like chlamydia, sir, and they can cause anal inflammation, and they can cause rectal bleeding. Secondly, sir, although not seen commonly in India, HIV with a Kaposi sarcoma can present with rectal bleeding if it is present in the rectum, sir.
Good. Any other condition that you would like to have or like to consider? Need not necessarily be applicable to this case, but needs to be considered in any patient who comes with a middle-aged or elderly patient who comes with a short history of colonic symptoms with mucoid discharge, blood.
Ischemic colitis, sir.
Ischemic colitis. So usually what is the setting?
Sir, they are middle-aged or old-aged patients, and they have underlying cardiovascular disorders, and they present with they can present with a large bowel diarrhea, and it can be associated with blood in stool, sir, and with abdominal pain also, lower abdominal pain, sir.
Okay. Then anything else? Could it be a diverticulitis?
Sir, for diverticulitis, sir, generally abdominal pain will be present, sir, but the tenesmus and rectal bleed is a little unusual because bleed is generally caused by right-sided diverticuli, sir, and the left-sided diverticuli, they cause diverticulitis. So in that case, sir, it is difficult to explain the rectal bleed and the tenesmus, sir.
So this whole pathology or problem that this patient has, you think it is inflammatory or it is primarily a bleeding problem?
Sir, now it appears to be a bleeding problem, sir, primarily, sir.
And why so?
Because the frequency of the bowel movements, they have remained normal, and the patient also does not have any other systemic symptoms, and also no weight loss, ma'am. So it's difficult to categorically say that it is inflammatory, ma'am.
Okay.
I would consider it, but
one thing you should always not forget about is a diverticular problem. In fact, this is a classical presentation of an inflammatory, something that is causing some inflammation in the distal colon, the rectosigmoid region, and diverticulitis can quite often produce these sort of symptoms with blood staining of the stools. This is not obvious bleeding of a classical diverticular bleed, but you can have blood staining of the stools because of inflammation with mucoid discharge and pain. And very often it is usually the lower abdomen or left lower abdomen. Okay, so
I think there's one good suggestion which has come, and I think we should have discussed that, and that is SRUS.
Yes.
So in the history also, we should have asked,
in fact, I was coming to that this thing again.
Yeah. Right. Dr. Ajit has given this suggestion. we should actually rule out SRUS. The only thing is it will not present with obstipation normally, but then otherwise it can have, so the history and then cause further evaluation. So
okay. So now we go on to, so what next? What would you like to do?
Sir, I would, yes, sir. Sir, I would go for an examination of the patient, sir. A systemic examination of the patient and with a per rectal examination, sir.
Per rectal examination, what are you going to see? Look for?
Sir, yes, sir. So for the per rectal examination, sir, I will go for inspection in which I will like to see for the skin around the anal region, sir. And if there are any skin tags or fissures that are present, I'll also ask for the patient to strain and see whether any mass or any rectal prolapse is present or not, sir. After that, sir, I will go for the insertion of the index finger, and I'll look for the tone of the anal, the resting tone of the anal canal, and I'll ask the patient for straining and squeezing, and also I will look for the mucosa of the uh, uh, anal canal and the distal rectum, sir, and if any mass is palpable in the mucosa, whether the mucosa is velvety, and also I'll look for the perineal descent, sir.
Okay. So you've gone through all this, looks quite normal. What next will you do?
Okay, so
for diagnosis, I don't want all the other, the blood test, the hemogram, this thing, that thing.
Okay, sir. Sir, then I'll go for a
for diagnosis, for clinching the diagnosis. What is your next test that you're going to do?
Sir, I'll go for a X-ray abdomen first, sir, because the patient has obstipation, sir.
History of obstipation. Plain X-ray abdomen shows some fecal-laden distal colon, but there's no feature of obstruction.
Okay, sir. So then subsequently, sir, I'll plan for a sigmoidoscopy, sir, unprepared sigmoidoscopy, sir.
Unprepared sigmoidoscopy. Okay. Why not a prepared sigmoidoscopy?
Sir, because my primary intention over here is to look for the involvement of the rectum and the sigmoid, sir. And since the patient has obstipation, sir, it will be difficult and to
you do an unprepared sigmoidoscopy only when the general condition or the condition of the bowel does not permit a preparation, and when you have to take quick decisions. So in this patient, of course, you're right. If you have to get a quick diagnosis, an unprepared sigmoidoscopy, but there's always this problem that the rectum may be laden with feces and it may cause problems. So it may be worthwhile, actually, if the patient does not have any other problem, to give a good bowel wash or something like that, a preparation, and then go and do a sigmoidoscopy. So now describe. This patient was taken up for a colonic evaluation, and after a complete preparation, what is seen?
So the rectal mucosa from the anal verge 10 centimeter, it shows that the mucosa is inflamed, edematous. There are superficial ulcers and erosions, and there is loss of vascularity, sir.
Okay.
And
do you think there is friability?
No, there might be a friability also, ma'am, but there is no luminal or spontaneous bleed.
So no spontaneous bleed. Okay. Then what else? So I want you to describe what is it, what is the disease extent, how will you classify this disease, and how do you grade the disease activity?
Yes, sir. So the disease extent is classified according to the Montreal classification, like E1, E2, and E3, sir. So here, since only the rectum is involved, sir, it will be E1, sir.
Okay.
Then, sir, this grading is done according to the UCEIS score or according to the Mayo score, sir. So in the UCEIS score, sir, we have 3 components. One is the vasculature. One is the bleeding, and the third one is the presence of erosions or ulcers. So since this patient has a complete obliteration of vasculature with erosions and with but there is no luminal bleed or spontaneous bleed, but friability is present, sir. So the UCIS score will be probably 5, sir, for this patient, sir. And and the other score that we can use
Any
is
other
the
scoring
Mayo.
Scoring system that you know?
Yes,
How
a
does
Mayo
the
score.
differ from UCIS?
Mayo score and the Barron score is there, sir.
Okay, how does the Mayo scoring system differ from the UCIS?
So the Mayo score has 4 components, but only one component is the endoscopic score. The other 3 components are the physical assessment by the physician. The third one is the rectal bleed, and the fourth one is the frequency of stools, sir.
Okay. So that is the Mayo Clinic disease activity score and other system. This is basically what I was asking you. This is the Mayo, where frequency, rectal bleeding, findings of endoscopy form one component, and you have the global assessment also. And then this is a score according to which you classify it as clinical remission, mild active, moderately active, or severe. And this is a UCS. It's a slightly more complicated, but it is strictly an endoscopic scoring system, right? What you should remember, this is a patient with ulcerative proctitis. Now, this is where you must know that diarrhea is not always present. Obstipation or constipation may be reported, and rectal bleeding and mucoid discharge is the most common symptoms. And one thing that we must always keep in mind is that it need not be a simple problem to treat. The treatment can be challenging, and very often these patients are very, very symptomatic. And a large proportion of them would relapse within 1 year of medication discontinuation. So,
just
Kushan,
another quick thing I wanted to tell you, Kushan. When you're doing the UCIS scoring, always mention that UCIS scoring is done from the most involved segment. The scoring, it's not like in general for the entire. So the most active place is where the scoring is done from. I think that you should remember when you're reporting it and which region that is.
Okay. Okay.
So, Kushan, how will you treat this patient? I want you to address all these.
Right, sir. So, sir, regarding the diet, sir, I will advise 25 to 30 kilocalories of diet with 1.4 gram per kilogram of protein. And there is no recommendation, sir, regarding any, restriction of milk or milk products in ulcerative colitis, sir.
When will you restrict milk and milk products?
Sir, if the patient has coexistent lactose intolerance, or there is a, if there is a suspicion of Crohn's disease, like if we are not able to differentiate between the two in that case.
What is this? Does this have to do with Crohn's disease?
Sir, in Crohn's disease flare, sir, the patients may develop secondary lactose intolerance. So during the flare, we can restrict the milk or milk products. Sir.
So basically, if a patient reports any intolerance to milk and milk products, you restrict milk and milk products. Otherwise, you don't. Okay.
Yes,
activity, no restriction. What about oral medications? What oral medications will you give this patient?
Yes, sir. Sir, so for this patient, sir, the patient has moderate ulcerative colitis. So I will start with oral mesalamine, sir. The dose for oral mesalamine will be, sir, 2.4 to 4.8 grams in 3 divided doses, sir.
Okay, so you will give this patient oral mesalamine. Any other medications?
Yes, sir. Sir, and since the patient has a proctitis, sir, I will also add topical mesalamine, in which case the dose will be 1 to 4 grams, sir.
What topical mesalamine preparation will you prescribe for this patient, and why?
Sir, the topical mesalamine preparation, like
What topical preparations do you know of?
Sir, Pentasa, Pentasa enema, or sir, actually, sir, it can be a foam, it can be a suppository, or it can be a enema, sir.
So what is the difference between a suppository, a foam, and liquid enema?
Yes, so the suppository, sir, it has it acts only in the rectum, sir. The foam can act up to 18 centimeters from the anal verge, and then enema can act up to the splenic flexure, sir.
That is a foam enema.
Sir, the normal enema also will act up to the splenic flexure, sir.
Okay. So in this patient, what will you prescribe?
Sir, in this patient, sir, a foam will be sufficient, sir. A foam or even a suppository will be sufficient, sir.
Why not suppository alone? It's just the lower 10 centimeters.
Yes, ma'am. Suppository also will be enough. No?
You did not necessarily agree with the examiner when she says suppository is good enough. Why you don't have to agree? You mentioned earlier that you'll be using a foam enema, isn't it?
Yes, sir, but suppository can also be used, sir, because only proctitis is present, sir. So,
Dr. Rupa, you were saying something?
Yeah, no, I was just saying that, in fact, when you are putting in the foam, usually the rectum gets spared. It doesn't reach because the nozzle goes beyond the rectum, unless you explain it very clearly.
Nozzle. Okay.
Yeah. So that's the reason why sometimes suppository, in fact, yeah, even for left-sided, you can actually give a combination with a suppository because the distal part is taken care of. And the distal part is the part which is actually responsible for most of the symptoms, you know, the urgency, the thing. So that part you can add a suppository, it usually will work well. And I think at this point, I will also tell that there's a question which has come up, that what is the reason for the constipation? So the
reduced proximal colonic transit in proctitis patients.
Yes, one is that. The other common reason is there will be one diarrhea, and then there is so much of rectal straining post the diarrhea that the patients tend to develop a kind of constipation because the rectal muscles and the surrounding, there is a strain. So that could be another reason why there was constipation in that patient. So these are important points to remember, that sometimes in proctitis, because of these reasons, there will be constipation.
So what will you counsel this patient in addition? You just say that you'll tell this patient to take a suppository or a foam enema. What are you going to tell this patient?
Sir, I'll tell this patient that these medications will go on throughout the life of the patient, and she may be having a relapsing course, and she needs to come for a regular follow-up, and I will plan the next colonoscopy approximately 3 months after I have started the medications, and I will also plan for a CBC and fecal calprotectin after 3 months, and then subsequently after 12 years, I mean, she'll also require, sir, screening for colorectal malignancy at a later point of time, sir.
Okay. Now, basically, this point about calprotectin and colorectal malignancy and ulcerative proctitis, it does. These patients do not have more often than not the calprotectin is negative, and they are not considered to be pre-malignant, or the incidence of malignancy is not considered to be higher than the rest of the population, unlike the ulcerative colitis or pancolitis or even left-sided colitis. Okay, so basically this is what is the recommendation is that in confirmed ulcerative proctitis, very often suppository alone is good enough. You need not go in for tablets because they will all add on to the expense of the treatment. Very often these patients improve with suppository alone, and whenever suppository has been given, you have to strictly instruct the patient that it is to be taken before bedtime, before the person goes to sleep, and just before the patient goes to bed, right? And very often if there is a response, then maintenance suppository can be decreased in frequency and they can be maintained on suppository. Only if there is no response, then you go in for addition of 5-ASA. And this is where the suppository acts, the foam and the liquid goes much higher, right? So now we continue. The patient was diagnosed with ulcerative proctitis, started on mesalamine enema with complete response after 2 weeks and then discontinued therapy. 4 months later, 5 to 6 diarrheal bowel movements daily with visible blood in each bowel movement, and with nocturnal symptoms with tenesmus. Now, Kushan, what do you think has happened and what would you do?
Sir, this is a exacerbation of the symptoms, sir, and the probable reason could be because of the poor compliance and because the patient had stopped medication, sir. But at that point of time, I will also rule out if the patient was taking any NSAIDs, if the patient had any superadded infections also, sir.
This patient was put on 5-AS, oral formulation as well, just like you had suggested, and this has been going on. So do you think, what are the differential diagnoses that you would like to consider in such a situation?
Sir, one of the possibilities could be the exacerbation of the acute ulcerative colitis that the patient had.
Yeah.
Secondly, sir, it could be an infection on an underlying ulcerative colitis, sir.
Okay, anything else that you must keep in mind? What infection are you talking about?
Sir, infections could be, sir, a CMV infection or a Clostridium difficile infection, or even other infections like Shigella, Salmonella.
Okay. For all the residents, just for information, it is now it's not now referred to as Clostridium difficile. The new name is Clostridioides difficile. That's the latest terminology. Okay. Okay. So you can think of C. diff, you can think of CMV, you can think of other infections. Anything else that you would like to keep in mind? Sometimes,
a small comment here that usually when there is ulcerative proctitis, CMV co-infection with proctitis is surprisingly very low. So in this case, that it always becomes spontaneous to answer that it is going to be Clostridium difficile or CMV. It's okay, but for ulcerative proctitis, usually a CMV co-infection is not that common. But yeah, I mean, you can say it for theoretical purposes, but no, usually that is much less common. So you will either think that this could be a relapse of the disease or not. I think that should be one of
obviously the patient had not been counseled properly and the patient stopped medications, but basically it is an incomplete induction therapy. At this point, a repeat flexible sigmoidoscopy was done, and at that time it was found that the extent of the disease had gone up, and even it had gone up to much beyond the splenic flexure. Okay, now if you look at the history, and she's got about 6 to 7 bowel movements per day, all blood stained, what do you think would be the disease severity, Kushan?
Sir, according to the Tulip and Witts criteria, sir, it will come as a moderate ulcerative colitis, sir.
It will be moderate. And you mentioned about Mayo severe clinical Mayo Clinic's disease severity and UCIS. Now, if you look at the Mayo Clinic here on the right side, I've put, so what would be the, where will you put the disease activity? Stool frequency? How much?
Stool 5 to 6 times. So it will be
rectal bleeding?
rectal bleeding also.
Obvious blood stools, blood with stools most of the time. Findings
Yes,
on endoscopy, I mentioned on the left.
Yes, sir.
So what will it be? Let's take it as 2.
2. Yes, sir.
And physicians, that global assessment, okay, even if you put it as 1 or 2, how much is the score?
Sir, 8, it's coming, sir.
So what will it be?
Sir, in that case, it will come as severe.
Okay. How would you treat this patient now?
Sir, now the patient will require oral corticosteroid in the form of prednisolone, sir. So the dose will be, sir, 40 to 60 milligram.
Okay, so you would like to put this patient on. How will you? What will you start and how will you proceed?
Yes, sir. The dose will be 40 to 60 milligrams, sir, once daily, and I will continue with the same dose till the patient achieves symptomatic improvement. And after that, sir, I will taper the corticosteroids like 5 milligram every in 5 milligram decrements till 20 milligram, and subsequently with 2.5 milligram decrements, sir. And the total duration should be 3 months, sir.
Okay, so basically this was a proximal extension of ulcerative proctitis, which is seen in about 25 to 50%. And you must always keep in mind that whenever such a thing happens, it is associated with a poorer prognosis and they require more aggressive therapy. Now, who's the second resident?
Sir, I'm here, sir. Praveen.
Kushan, after Kushan, Kushan,
Dr.
thank you very
Praveen.
much. You did
Thank you, sir.
quite well. Praveen.
Yes, sir. Yes, sir. I'm
Praveen
here,
from
sir.
Kim's Trivandrum.
Praveen, you've been following this case. Now, how will you treat this condition? He has mentioned, Kushan already mentioned that he would put this patient on a combination of oral aminosalicylates and steroids. Now, what this patient had been put was earlier, the patient was on suppository, was added on mesalamine, but symptoms increased despite mesalamine. So I think one thing that you must always keep in mind is that sometimes mesalamine can cause a hypersensitivity and that can cause a problem. Okay, so now treated with mesalamine and the symptoms increased despite mesalamine, what would you do next? The prednisolone was started, as Kushan was saying, and with a good prompt response, but increase in symptoms around 20 milligrams per day. So she was maintained on prednisolone for between 20 and 60, depending on the symptom control, for almost 2 years. So now, Praveen, I would like you to answer these questions. Was it the right choice? What would you have done? And what are the possible outcomes after starting steroids in patients with ulcerative colitis?
Sir, this patient, in spite of on weaning of steroid, patient started developing symptoms. So probably she may having a steroid dependency state. So ideally, along with that, patient should have started on steroid sparing agents like Thiopurines. So possible outcomes after starting steroids is patient can recover and may go for remission and patient can be weaned off. Otherwise, patient can become a steroid dependent ulcerative colitis, like this patient who whenever the patient weaned off from steroid, they may have a relapse of symptoms. So probably it will be a steroid dependent ulcerative colitis.
So you think this patient is a steroid dependent ulcerative colitis?
Yes, sir.
Now, a patient with ulcerative colitis is started on steroids. What are the possible outcomes, and what are the chances of this patient going into those outcomes?
Most of the patients with steroids, they will go for a remission of the symptoms, sir, with prompt dosage within 3 to 5 days. The symptoms will start reducing.
What proportion of patients with ulcerative colitis started on steroids will respond and go into remission?
Around 50 to 60% of patients will.
How much?
50 to 60% of patients will go for remission.
Okay, then what happens to the rest of them?
Patients may go for steroid dependency state, sir.
Okay. What
And
proportion?
few patients may not proportion 15 to 20% of patients will go for steroid dependency. Around 10 to 15 will be a steroid refractory patients. So in spite of racing steroid, they may not develop remission at all.
Okay. So what I would like you to remember, residents, is that you remember this 50, 20, and 30. The chances of a patient going into remission after receiving steroids for ulcerative colitis would be roughly around 50%. At 1 month, it is 50% complete remission, 30% partial remission, the remaining 20% you can say no response. Similarly, at the end of 1 year, 50% will have prolonged response. There'll be 30% who will end up with surgery, and about 20% will be steroid dependent. These are roughly the results of a trial which was published in 2001. Still, it holds fairly okay, but with the biologicals and all having come in, the results would have changed a little bit. Rupa, your comments.
I agree, but I think the steroid dependency is quite high. Steroid resistant is very low. I think that 20 maybe more towards the steroid dependent more, because steroid resistant cases are quite very much lower.
We move on with the case. This patient then presented to an academic center. At that time, this patient has 10 to 12 bloody bowel movements per day, passing pure blood and clots, significant tenesmus, urgency, cramping, low-grade fever, weight loss. She is anemic, she's hypoalbulemic, and the CRP is high. In the emergency department, she was given Solumedrol 60 milligram IV every 6 hours. And then, of course, that is when you are called in. So, Praveen, I would like to ask you, is this acute severe ulcerative colitis? What is the definition of acute severe colitis? And how would you grade the severity of acute severe colitis?
Yes, sir. This patient, and currently the presentation is a feature of acute severe ulcerative colitis, sir. Since patient is having a frank blood in stools and associated with anemia, weight loss, and having toxic features like the high CRP and all. So
how will you define acute severe colitis as ulcerative colitis? What is your definition of an acute severe ulcerative colitis?
So patients who are having a presentation of a blood in stools along with anemia as well as weight loss and high CRP.
All three have to be present? One or two, one of the three have to be present, two of three have to be present?
So actually that True-Love criteria in that if it comes severe ulcerative colitis presenting like an acute symptom, it can be an acute severe ulcerative colitis we can take.
True-Love and WITS criteria, what does it give? What does it tell you?
Severity of the disease, sir.
It tells you the severity of the disease. So what is severe diseases? Anything more than 6 bowel movements per day?
With blood in stools and hemoglobin less than 10.5, ESR, CRP elevation, and fever, temperature of more than 37.
What are the absolute indications for surgery in patients with acute severe ulcerative colitis? We're not going for any medical treatment, straight away surgery.
Patients who have symptoms of toxic megacolon or colonic perforation.
How do you diagnose megacolon in a patient with acute severe ulcerative colitis?
The first we have to take an X-ray abdomen to look for features of a dilated bowel, and that by further transverse colon diameter of more than 6 centimeters is suggestive of a toxic megacolon in the setting of an ulcerative colitis. Okay. And
anything else that is an indication for surgery straight away?
There is a features of perforation or patients who are already medically refractory patients who are having a repeated episodes of relapse or severe ulcerative colitis. They are also may need a surgery.
So toxic megacolon and perforation are straight away indications for surgery. You're not going to look left or right, straight away to the surgeon and then ask the surgeon to take over and do it. Okay. So basically, acute severe ulcerative colitis, more than 6 bowel movements in 24 hours, and one or more of the following. That you have to be very specific. One or more of the following, and these are the 4 criteria. Any one of them, along with 6 bloody bowel movements per day, will categorize this patient as acute severe ulcerative colitis. Okay, that is an indication for severe disease activity. And this is the one that you were referring to, the rule of Witts, where it is classified as mild, moderate, or severe based on various criteria. There is another classification, Montreal classification, which includes abdominal pain, and anything that is stool frequency of more than 10 becomes fulminant disease with colonic dilatation. And toxic megacolon, and these are the various things that are criteria for toxic megacolon, right?
Okay, sir.
Okay, so these are things that you must remember. Who's the third resident?
Sir, good evening, sir.
Karthik,
Dr. Karthik.
Karthik, welcome. Karthik from Apollo.
Yes, sir.
Now, what is your diagnosis in this patient? This patient has got acute severe ulcerative colitis, has been on steroids for a long period of time. How do you manage a patient with an acute severe ulcerative colitis? And what are the criteria for guiding therapy?
Okay, sir. Sir, for management, sir, all patients will be admitted first. We would monitor these patients, sir. Basically, we have to examine these patients and we have to check in specific for bowel sounds, because absence of bowel sounds means the patient could be going towards a toxic megacolon. We would monitor the patient's electrolytes and correct any dyselectrolytemia that would precipitate toxic megacolon. We would give IV fluids and IV antibiotics, and as per the Oxford regimen, we would give IV hydrocortisone 100 milligrams 4 times a day, or we can give an equivalent dose of methylprednisolone, which is 60 milligrams per day. We would anticoagulate these patients because they are prone for deep vein thrombosis because of the pro-inflammatory state. We'll give low molecular weight heparin. We would avoid NSAIDs, and if the patient is receiving any antidiarrheals, we would avoid that. All opioid medications would be avoided in these patients, sir. And IV fluids will be given. The criteria to guide for therapy in this patient, sir. We would check on day 3, sir. We check the stool frequency as well as the CRP levels. If the stool frequency is less than 3, that means the patient has responded. It's a steroid responder, and more often these patients will respond to medical therapy. If the patient has a stool frequency of more than 8, then this patient is likely a non-responder. And added to it, if the CRP is also more than 45, then it is a non-responder to steroid therapy.
So what is this criteria called?
Sorry, sir?
What is this set of criteria called?
So that the Travis score, sir.
It's otherwise known as Oxford criteria. So of course, first Professor Simon Travis was a person who came out with this criteria. It's called more popularly known as Oxford criteria. So,
and I don't think IV antibiotics as a routine is indicated. So when you start off, you should not mention that I will be giving antibiotics. It's a common practice that is done. I don't think you should mention antibiotics. Leave it for that to be questioned, because there are gray zones there. But in general, for acute severe ulcerative colitis, you don't need antibiotics.
Right. So what? Can you be more specific? At day 3, you're going to look at the bowel movements as well as whether blood is there and the CRP, isn't it?
Yes, sir.
Okay. So what do the criteria say?
Sir, the criteria says that if the patient has a stool frequency of more than 8 times, or if the stool frequency is between 3 to 8 times with a CRP of more than 45, sir,
Yes.
These patients, if these two are there, then usually you offer these patients a second line medical management or colectomy, and these patients have a predicted risk of colectomy of close to 85%.
Why? Yeah. Okay, fine, good. So basically, this is what the algorithm will look like, and maybe in pediatrics it's slightly different, but in adults, what you mentioned, Karthik, is that you mentioned about the intravenous hydrocortisone or IV methylprednisolone and the low molecular weight heparin, which is good. Baseline investigations, including stool microbiology, including for C. difficile, that is something which is important. And then a review on day 3. And these are the criteria, but I think as residents, you just remember Oxford criteria, and that is what is important. There are other criteria, you don't have to remember all those. And on day 3, basically you're going to look at this 4 bowel movements and no rectal bleeding as this thing. And on day 3, if these criteria are not met, there is an exit strategy. You can go in for an emergency colectomy, or you can go in for rescue therapy, which will be either infliximab or cyclosporine. Right? Yes. So this algorithm is something that you must all remember. I think for all the residents, these are the important things that you need to keep in mind. The Mayo score, the UCAS, the Oxford criteria for acute severe ulcerative colitis, the diagnostic criteria for C. diff and CMV, and of course the definition of acute severe ulcerative colitis and the catheterization. So these are the important things that you'd. So what would you do now? This patient has come to you and has got 10 to 12 bowel movements, has been started on IV fluids, IV steroids. On day 3, this patient shows a favorable response. Then what would you do?
Sir, in that case, sir, we would continue the steroids, sir.
Mm-hmm.
And we would continue it as IV till the patient patient has a normal stool bowel frequency, sir.
Okay.
And meanwhile, we would the other things we would monitor is like we mentioned, sir, the electrolytes and fluid. If it's to be given a restrictive bowel blood transfusion strategy, because the patient would have lost blood, and
okay.
Apart from
but we did a sigmoidoscopy because this is, remember at the very beginning we said unprepared sigmoidoscopy, and this was a sigmoidoscopy. What is this? What does this show?
Sir, it shows the image to the left shows not shows the left. So it shows ulceration, so deep ulceration with loss of normal vascular pattern, sir.
What would you consider? What are the possibilities that you would like to consider?
Sir, I would want to rule out Clostridium difficile infection in this patient, sir.
Okay. So what would you do if you're thinking of Clostridium difficile? What would you send for?
So I would send the stool specimen. Sir, there are 2 approaches. So we can send the stool for a GDH, and if it's positive, we can do a toxin. And if the toxin is also positive, it will confirm. Or we can do a nucleic acid amplification test that has a very high sensitivity and specificity. And if it's positive, it proves.
Good. So basically, this is how you would zero in onto a diagnosis of C. diff. And it has to be a combination of toxin and GDH. That is the latest of the guidelines which mention. And based on these 2, and you remember, this is the combination that you need to look at. And that is how you'll go in for C. diff. So basically, it's important for us to understand that these are all high risk factors for C. diff. and this patient was treated with IV metronidazole and oral vancomycin, and the patient improved. Okay, fine. I come to the end of this this particular case, and it is over to you, Rupa, for the next bit for your case.
Oh, okay.
So thank you, Karthik. The next person will be Dr. Joe.
Thank you, ma'am.
Good evening, ma'am.
Can you see my screen?
Not yet. Yes,
No.
coming. Yeah, now.
Yes, ma'am.
Yeah.
Hi, Joe. Good evening.
Good evening, ma'am. Good evening, ma'am.
So I'll tell you, I mean, I think we went through the details of how to manage IBD in general in the guise of ulcerative colitis though. So we will be just discussing the objectives today will be management of complicated IBD. So there will be a case of perianal or fistulizing Crohn's disease and Crohn's disease with extraintestinal manifestations. So,
Okay, ma'am.
Dr. Ruba, can you put it on slideshow? It will be better visualized.
Yeah, is this okay?
Okay, great.
Oh, yes.
Yeah, so this is our first case, and as you see, you know, this is one of the worst kind of patients which are difficult to handle, being a doctor himself. So this is a 32-year-old male general surgeon, and this is his history. 2005, aged 17, he had perianal abscesses, incision and drainage, and then antibiotics were given. 2005 to 2009, there were recurrent perianal abscesses. There was no diarrhea, no pain. 2010, he developed diarrhea. Colonoscopy showed deep ulceration in the rectosigmoid. He was diagnosed as Crohn's disease, and then he started treatment with corticosteroids, antibiotics, azathioprine. 2012, there was ongoing perianal pain and discharge. He started adalimumab. And then in 2014, when he found that there was inadequate response to adalimumab, he switches to infliximab. 2014 to 16, he is on alternative medications, doing more or less okay is what he feels. And the infliximab becomes, he stops the infliximab. 2016 to 2020, this is the time when he has been coming to our hospital, ongoing perianal pain, discharge, intercurrent antibiotics, multiple examinations under anesthesia. He himself restarts adalimumab with azathioprine because he feels that last time it was not given in combination. And then now we are discussing defunctional stoma and vedolizumab. So this is a patient in whom he's unable to work, he's depressed, finding it difficult to even, accept the concept that a stoma will be needed. So the first question is, for this case, now that you have heard it, what were the errors in judgment here? So this is your case. When you go through this, what were the errors in judgment? So we'll just go through it quickly.
Ma'am, actually, at present, he is a 32-year male. So 16 years back, he would have been very young. That means he'd be 15 or 16 years old.
Yes.
So at such a very young age, and with diagnosing of with multiple perianal abscesses, and later on within 5 years, he was diagnosed to have ulcerative colitis. It would have been better to go for a top-down therapy because initially itself he should have been started with these anti-TNF or these more immunomodulator, means anti-TNF would have been a better option, I would feel.
So here there were many lapses actually. So you mentioned one, but we would first say that there was a diagnostic delay. So any recurrent perianal abscesses, he should have undergone a colonoscopic evaluation or a fecal calprotectin or assays earlier. The second, there is inadequate early management and assessment. So this is a person who earlier has had multiple recurrent perianal abscesses, but despite that, in 2010, because only diarrhea and colonic symptoms were predominant, he was started on treatment with corticosteroids and antibiotics. That was the second problem. And then if you see, he switched between the same class. There was no drug monitoring. There was loss of response to adalimumab, and he switched to infliximab. And then there was discontinuation of treatment. There was no thiopurines given together with it. Yes. And finally, that's the reason why what we call there is decreased optimization of therapy. So if you see, these are the factors that the first thing that you have to keep in mind whenever there is a patient with a recurrent perianal disease or fistulizing disease. So fistulizing perianal Crohn's, just to go back quickly, it occurs in about 1/4 to half of all patients with Crohn's disease. The cumulative risk is around 12%. In 10%, it is actually the initial manifestation of Crohn's. 1/3 will have recurrent fistulas, 2/3 will have multiple fistulas, and of course, it is associated with a very bad psychological burden. What are the causes? It is a combination of causes: microbiological environment, immunological environment, high pressure zones, wound repair, genetic predisposition, all combined. Avoid diagnostic delay. This is again another message, because there will be many who will have first just the perianal disease, and then they will be having the Crohn's disease. So these are the things, the basic things that you need to remember, because in 10%, perianal disease is the initial manifestation, occasionally only manifestation. And if you see a perianal abscess, fistula, consider Crohn's, take a full history, including luminal symptoms, extraintestinal manifestations, and family history. Now, which investigations would you do for this patient? If this patient had come to you with a history of recurrent perianal abscess, what are the investigations you would have done?
Definitely, ma'am, I would like to assess the disease activity by the initial hemogram and the inflammatory markers.
Yeah.
A fecal calprotectin will also may give a clue about the disease, the inflammation and the disease activity. And specifically to assess the perianal region, the options can be, you can do an MR fistulogram, or you can do a endoscopic, rectal endoscopic ultrasound examination of the rectum, or the gold standard is considered to be an examination under anesthesia to assess if there are complex fistulas.
I think, yes, that's the right thing. So investigate fully. Initially, it's going to be just, basic blood parameters and a fecal calprotectin, and then ileocolonoscopy with small bowel imaging, including MRE. And this is even before the patient has any colonic symptoms, because there might be ulcers which we can, and capsule endoscopy if it is warranted. Now, what is the first step in the assessment of perianal Crohn's disease? What is the first thing that you will do? Patient with known Crohn's disease comes with perianal disease. What is the first thing that you will do?
Or known Crohn's disease with perianal disease, we'll definitely take a treatment history, ma'am. How well is the symptoms were, whether the flare history is, how compliant he was with the treatment, and definitely those two mainly, ma'am, about the history and the compliance to treatment, how good he was with compliance.
And what would you examine? First,
mainly perianal region would definitely will examine the external perianal region to assess if there is any obvious perianal fullness, any abscesses, or any draining draining sites in the perianal region.
Yeah, so I think the first thing that you have to do is a physical examination whenever there is a fistula. And you're right, there are three things. One is there a fluctuation? Is there a stricture? Or is there no fluctuation, no stricture? Once this is done, then you know the basic way of which way to go ahead. Because if there is fluctuation, in that situation, the examination by the surgeon or EUA, examination under anesthesia, becomes important. If there is a stricture, then the colonoscopic assessment or dilatation or treating the stricture becomes important. So to decide on which way to go, it will always be for perianal, there will be multiple aspects. So only on the basis of this, you will be taking that decision. So that is going to be the first. After this, which modalities come next? And I think you have clearly mentioned, and I think that is right. The first will be the radiologic. You can just do a
transrectal ultrasound.
Yes.
And MR fistulogram, and then endoscopic ultrasound.
Yeah, if you have it, then endoscopic ultrasound. And then, of course, we know that we'll have to do a endoscopy to see for any stricture. And the third will be examination under anesthesia for drainage, for any seton placement and whatever.
Or any
yes.
Joe, what information does MRI give you? What information does a transrectal ultrasound or EUS give you? What are things that you're going to look for?
So the MRI definitely will give us an idea about the anatomy of the fistula. And so if it is, you can classify the anatomy according to the track of the fistulous tract. So if it is just a simple tract, that means it just tracks outside the external sphincter. And according to the Parkland classification, you can classify it as simple or complex perianal fistula. If complex, if it is the
what is complex?
It can be intersphincteric, it can be transsphincteric, it can be extrasphincteric also. So that all these anatomy of the fistula, because the treatment also varies. With if it's a complex fistula, the treatment varies. If it's simple fistula, also the treatment varies.
So what is the definition of a complex fistula? You mentioned one is when it crosses a sphincter. That is a complex fistula. What else is a complex fistula?
I think you should have a very clear idea about the types of fistulas. So can you give us the types of fistulas?
Ma'am, fistulas can be broadly classified into simple and complex. Simple fistula is just superficial. That means it doesn't involve the sphincters. It just tracks along the subcutaneous tissue and it goes into the external opening in the perianal region. And among the complex fistulas, the various fistulas are transsphincteric, where it can traverse both the external and internal sphincter. Intersphincteric, where it can track between the plane of the internal and external sphincter. And extrasphincteric, if it can go like it goes beyond the dentate line and it goes above the both sphincters and drains externally.
So simple fistulas also, complex fistulas are not only all other than those simple, even intersphincteric can be simple fistula. So I'll just, so what classification do you use for fistulas? Any standard classification that you know about?
Parkland's classification.
Yes, so it's called Park's classification, and I think that is what you should follow. So this is just to tell you that if there is no inflammation, there is no stricture. If there's no stricture, there's no fistula. This is the usual algorithms. And if there's no fistula, there's no abscess. So how would you classify and describe fistulas? This has to be very, very clear. So if you see simple fistulas are those which are superficial fistula without crossing any sphincter or muscular structure. Intersphincteric also can be simple. If the fistula tract is between internal anal sphincter and external anal sphincter in the intersphincteric space. It is simple if it is low, but once it becomes high, then that becomes a complex fistula. Of course, suprasphincteric is complex, and this I think you should just keep it embedded, that which is simple and which is complex, because management will differ according to this. Sometimes for simple superficial fistulas, you can just have a simple antibiotic and wait as well. But for a complex fistula, it goes straight into the top-down mode for higher things. The next thing that I wanted to ask you was, so it's Sparks classification and you know this. The next is, now what about strictures? Remember, whenever you see a stricture in any Crohn's disease, you should learn how to classify it and how to describe the strictures. I think Dr. Ramesh will agree, because when this patient is going to another place, your documentation needs to be very perfect. That this is, yeah. So tell me how would you classify and describe strictures in general?
Ma'am, it can be either simple or complex strictures. Simple strictures are straight strictures, and depending on the length of the stricture also, ma'am. If the length of the stricture is less than 5 centimeters, it can be considered as simple stricture. Beyond 5 centimeters, and if it is tortuous and depending on mainly on the length of the stricture, ma'am. If it is more than 5 centimeters, it's considered as complex.
Yeah. So this is again another thing that you have to be very well prepared as to how you will describe. Whenever you're seeing Crohn's disease, mapping is extremely important, and mapping of strictures makes a difference in, again, judgment. So first is it an inflammatory stricture or a fibrotic stricture? So nowadays with MRI and those features, it's very, it's often we are able to differentiate whether it's a inflammatory or. Then is the stricture a web-like? Is it spindle shaped? Okay. If you see it, or is it ulcerated? Okay. And the third is it anastomotic or a secondary stricture? Is it a primary stricture with a proximal dilatation? So all these, if there is a primary stricture with proximal dilatation, this is grossly a fibrotic stricture. So once there is proximal dilatation, these patients, we should not experiment with a lot of biologics, because the possibility of a fibrotic stricture will be much higher. Okay. So when you are writing it, it has to be based on etiology. Is it primary, secondary, benign, malignant? The number, is it single or multiple? The degree, is it tight or a low-grade stricture where scope is negotiable, easy? That's the easiest way to describe it. Then the shape, the length, which you mentioned already, then the location, okay? And then associated conditions. Is there proximal dilatation? As I mentioned, that has significance. Is there associated fistula, abscess, prior history of stricturoplasty? So all these need to be mentioned when you are describing a stricture, whenever you see a stricture in your practicals as well. Okay? Now, how would you differentiate between inflammatory and a fibrotic stricture? So I've just put up two pictures over there. So now, which do you think is inflammatory and which do you think is fibrotic?
The one on the top.
I think, Dr. Ramesh, I made this simple.
Ma'am, hello. Ma'am, can you hear me? Hello.
Yes, I can.
Ma'am, the image on the top, we can see the various signs of active inflammation. We can see the vasculature, it's called the comb sign. And also we can see the mural stratification of the mucosa. So all this would favor an inflammatory stricture over a fibrotic stricture, because it all shows active inflammation in the study. But whereas in the second picture, the vasculature, the mucosal enhancement is not so much, and also the walls also looks a bit more the muscular layer looks a bit more thicker, and also the inflammation, like the comb sign and all, the mesenteric hypervascularity is not much compared to the first one.
Yeah. So I think this is good description, and it was I purposefully made it simple. So in the first one, it is, of course, inflammation is present because there's mucosal. So remember these terms: mucosal hyperenhancement, mesenteric fat stranding, and the Coombs sign. It goes in favor of an inflammatory stricture. And if there is fibrosis, you will see abnormally thickened valve without signs of active inflammation anywhere. And again, as I just mentioned, dilatation of the proximal strongly suggests a fixed chronic obstruction.
Okay.
So what would be your approach to management of fistulizing Crohn's disease?
I think, can we have, after Joe, who's the next resident?
Rohan from
Yes. Yes, sir. I'm the next resident.
Rohan,
Okay, Joe,
Yes.
thanks. I hope you've learned
Thank you, ma'am.
something.
Yes, ma'am. Thank you, Raj.
Thank you. Thank you.
Rohan, can you be visible?
Yes, sir.
Yes,
Am I visible, sir? Yes.
Hi, Rohan. So you've been following that we are discussing fistulizing Crohn's disease.
Yes, ma'am.
We have identified that, yes, what would be your approach when you see a patient with a fistulizing Crohn's disease for management?
First of all, to begin with, the management depends upon the type of stricture, whether it's an inflammatory stricture or a fibrotic stricture. There are various issues to management. One is managing the stricture itself.
We are talking of the fistulizing disease. There is a fistula. How will you manage?
Yes, ma'am. So the issues with management is when it's a fistulizing disease. It's an inflammatory stricture. That means. So in that case, it comes as a high-risk behavior. So I would go for a top-down therapy in that case. So the ideal thing would be to start biologics for these kind of patients.
So Rohan, when you're seeing a patient, management does not only mean medical therapy, and particularly when you're dealing with a fistulizing Crohn's disease, it means a lot more than that.
Yes,
so whether it is an inflammatory stricture or a fibrotic stricture, once there is a fistula, what will you do? So comprehensively, what will you do?
Yes, ma'am. So first, if there is a fistula, I would like to first treat the abscess and the fistula with antibiotics. I would like to take care of the nutrition as well in this patient. For the fistula, I would like to treat with antibiotics in the beginning. Start biologics if it is not responding, and then the other rescue therapies would be stem cell therapy or video-assisted fistulizing fistula treatment. And for the stricture, since it's an inflammatory stricture, the top-down therapy, that is the biologics, would take care of the stricture if it's an inflammatory stricture in this case.
So supposing there is a fistula with an abscess, so yes, will you start treatment directly, or will you take the help of your surgical colleague?
Yes, ma'am. In that case, if it's a abscess associated with the fistula, it first needs to be drained. The infection needs to be controlled before starting any kind of immunosuppressive or biologic therapy. So in that case, I would take help of the surgical colleagues and go for a perianal abscess drainage.
Would you take help of your endoscopic colleagues as well?
Yes, ma'am. So depending upon the location of the abscess, there's a possibility that an endoscopic ultrasound guided drainage of the abscess also can be done.
So let me just, Dr. Ramesh.
Yeah. Rohan, as a resident, when you're answering this question, be sure that you go about it in a very systematic manner. Now, you mentioned in the beginning itself straight away biologics because of the fact that it's fistula. I mean, you must be careful because before that, there are many things or many steps that are to be followed. Now, what are the important things that you would like to do before you initiate or even think of doing putting a patient on biologics?
So first of all, it is to I need to rule out any presence of any infections. I need to do a screening for tuberculosis, hepatitis B, antigen status, anti-HBC antibody status, and I would like to do a chest X-ray, a MANTU test, and interferon gamma release assay levels, and only then I would like to, after ruling out the presence of latent tuberculosis, hepatitis, or any other immunosuppressed state, only after that I would like to start on biologics.
Rohan, this is in general for biologic usage that
Yes,
you will take these precautions. But if a patient with fistulizing Crohn's disease comes, then even if he comes with this report that, okay, my latent TB is negative, okay,
yes,
will you even then start biologics at day one?
No, ma'am. First thing would be to treat with antibiotics with ciprofloxacin and metronidazole. Take care of whether the abscess, whether it can be drained or not. That would be the thing. And if it's I would like to give surgical treatment in the form of diverting ileostomy or a bowel rest. So that could help in healing of the involved segment of the colon.
So, Rohan, the message is you have all the information, but they are not set in the right perspective. Okay, so you will not go for diversion ileostomy first for your surgical colleagues. You will ask them whether a ceton placement is needed or not.
Ceton, yes.
Okay,
Sorry.
because unless so you'll have to think of those things, whether incision and drainage is needed or not, whether a ceton placement is needed or not. So remember, this is always Crohn's disease in for your exam purpose, for practical purpose. Never mention only medical treatment first. Your first statement should be, it will be a combined medical and surgical management, particularly if it is a complex fistula. Okay, for a simple fistula, sometimes you get away with maybe one antibiotic, but the algorithms are very clear. So what you will do is, first, you will check for fluctuation stricture or no fluctuation, which we've already done. If there is fluctuation, patient goes for examination under anesthesia, IND plus or minus a ceton placement. Followed by that, you will do endoscopy, you will do an MRI. Okay, to see whether there is other tracts which were not identified. Okay, because fluctuation is a painful condition and it needs drainage first. If there is a stricture, endoscopy takes predominance and you will do dilatation followed by MRI. Okay, and then we will take a decision whether a ceton placement is needed or not. So always it's a multimodal treatment, surgical and medical. The surgical part will be examination under anesthesia, incision, drainage, ceton insertion. And the medical part will be antibiotics, immunomodulators, biologics, or the combinations of these. Okay? Is that clear now, Rohan?
Yes, ma'am.
So combined surgical and medical therapy, there are a lot of studies, they're complementary, used in combination, and 53% respond to surgery alone, 47%. But if it is, you combine it, then it is almost 71% that there is a good response. So this was one very nice study where they were stratified according to the biologic usage. So what is the role of antibiotics? What is the role of steroids? And what is the role of thiopurines?
Antibiotics, if it's a simple fistula, then I would like to start with ciprofloxacin and metronidazole orally for about 6 weeks. That would be the initial line of management for a simple fistula. And even if I'm going to drain the abscess associated with, I would still like to start antibiotics along with it. Coming to the role of steroids, I would not consider steroids in an acute fistulizing Crohn's disease when there is presence of perianal fistulae and presence of an perianal abscess. In that case, steroids are absolutely contraindicated. In that case, it would lead to further worsening and flare-up. Regarding the role of thiopurines, they can be used as a maintenance once I achieve remission after the use of antibiotics or biologics, if I'm using biologics in that case.
No, I think Dr. Ramesh would like to comment on the thiopurines.
Rohan, first of all, about your comment on antibiotics, I thought you mentioned that you'll be using ciprofloxacin and metronidazole. What do the guidelines say? What guidelines have you read, and what do the guidelines say about the use of antibiotic the choice of antibiotics?
The ECHO guidelines of Crohn's disease 2020.
Okay, yes, what does it say?
So ciprofloxacin.
You use ciprofloxacin alone, ciprofloxacin metronidazole combination, or metronidazole alone? And how long?
Combination of ciprofloxacin and metronidazole for a period of about at least 6 weeks.
For a period of 6 weeks. And then what do you do after that?
I would like to reassess the patient. This is if there is a simple fistula. If and simultaneously if there is an abscess, I would like to drain the abscess as well.
Okay. Steroids is fairly well taken, but what did you mention about the role of thiopurines? You mentioned that it is used in.
How come the role of maintenance comes up here? When you're dealing with a fistulizing Crohn's disease, your statements have to be very well formed. What is the role of maintenance? Here there is a fistula, and you have a patient who comes and tells you, and so you will say that we will heal it with antibiotics and give you thiopurines, or what do you think? I mean, what is your plan?
No,
so how is the maintenance coming up?
Thiopurine, the basic rule would be when we are using it along with biologics, because it prevents the antibodies formation to the biologics, especially infliximab. That is the role where thiopurines would play a role. It decreases the immunogenicity of the against the biologics.
That is definitely, yeah, that is true. That is definitely one of the roles of thiopurines. But thiopurines are one drug which also has a direct action on reducing inflammation in perianal fistulas. Okay, so if you have a very poor patient who cannot afford biologics, I think thiopurines still has some role. Okay, so you have to be aware of that. Okay, so we'll quickly go through. So, you know, these are studies which have shown that even alone, if it alone ciprofloxacin or alone metronidazole has been used, the roles are not like it's not rocket science, but like we mentioned, for simple fistulas can be given. Usually the benefit is as an adjunctive therapy. So combined antibiotics plus thiopurine or anti-TNF, whichever you are using. So in that, a little long-term antibiotics has shown some benefit. Steroids, clearly no role. As a thiopurine and 6-MP, there is fistula response. So this is one important information which you should have. It's not only with biologics, and it is not only for maintenance. For fistulas, there have been studies which have shown that there is some fistula response when given for a long duration, and this was one meta-analysis of controlled trials, which fistula was assessed as secondary endpoint. Okay.
Yes, ma'am.
Of course, I'll not get into the details today, but when you're using azathioprine, you might want to check for TPMT, NUDT15. We need to read about that for Asian population, particularly now from India. We have so many studies. Dr. Devendra Desai has an elegant study from Mumbai where he has shown that NUDT15 is better than TPMT. We also had one study, and I think this came in APNT, where we again saw that in more than 1,000 patients, NUDT15 was better than TPMT genotyping. So possibly this has more role. What are the other immunomodulators that are used? In
Yes, ma'am. Tacrolimus, mycophenolate mofetil, then thalidomide. These are some of the other immunomodulators, and methotrexate are some of the other immunomodulators which can be used for the treatment of fistulizing Crohn's disease.
So this is just, you need to remember that these are other alternatives that. So what is the role of biologics?
Yes,
which biologic will you use and when will you use it?
Can we call the next person?
Yes.
Yep. I think we are short of time, right?
Yeah, Dr. Rohan, thank you very much. Dr. Snija, please.
Yes, sir.
Okay, please. Okay,
Good
Dr.
evening.
Ruba, please continue.
So we have almost discussed, Snija, that biologics we know are the thing for fistulizing Crohn's disease, but which biologic will you use? When will you use? And what is the role?
Ma'am, we can use anti-TNF agents or anti-integrins. When we can start straight away once the nature of the disease is aggressive, behavior of the disease is aggressive, fistulizing disease. We can.
What do you mean by aggressive or fistulizing disease?
No.
What do you mean by aggressive disease?
When it is a high risk fistulizing disease, we can, especially in a young patient, we can start as a step down therapy. If
it's a simple fistula, would you go for biologics immediately?
No, ma'am. In simple fistulas, we can try seton placement or other immunomodulators like azathioprine.
Would you check a colon before you do that? Whether there is, supposing there is a simple fistula and the colonoscopy, there's no diarrhea, there is no other features there. The Crohn's is quiet in the colon. So in that situation, will you go for biologics? So biologics usually is when there is a complex perianal fistula. I mean, sure shot you have to go together with active colonic disease. The rest would be more
conservative.
Yes.
Immunomodulators.
Immunomodulators, I don't think will be, if the patient can afford biologics for a complex perianal fistula, we will not do anything else. We will just go for surgeon, what they say, stricture dilatation. So I'll repeat it once again, stricture dilatation and then biologics, plus or minus with antibiotics. Now, which biologic would you use?
Ma'am, we can use infliximab or adalimumab or vedolizumab.
Okay.
Most of the evidence are with infliximab.
But when would you prefer vedolizumab?
Especially in elderly patient and where there is high risk of infections or a risk of malignancies. In such cases, we can go for vedolizumab, or patient is not responding to infliximab.
Good.
We can go for vedolizumab.
So primary or secondary loss of response to the first-line biologics, obvious high risk of tuberculosis, we should plan to go for vedolizumab.
Vedolizumab.
Yes. Sometimes, even when the patient is intolerant to thiopurines, okay, there has been a thiopurine induced, so then we can't give that. So in those situations also, since combo therapy is not needed for vedolizumab, it becomes one option. So these are the different factors that you should consider. So of course, now we know from immunomodulators, we reached the anti-TNFs, and that has made a lot of difference. Some of the studies you should always know the original studies which happened. So the accent you should be, you should be knowing about what was done for the accent and the different accent studies. Then for adalimumab, so all things, and then now the sub-analysis of vedolizumab in perianal Crohn's disease shows that, even with people who failed prior anti-TNF, there was a good closure rate with vedolizumab. So this was the Gemini 2 trial data. And again, we analyzed actually the Indian context. Always remember Indian context when you are speaking, because our algorithms will continue to be different. So the efficacy and safety in moderate to severe active Crohn's disease, it is same like in Asia as the rest of the world, but the risk of tuberculosis appears to be significantly lower. And now we have post-marketing surveillance studies also, which are showing that the risk of tuberculosis is low. So combination of anti-TNF, if you are giving anti-TNF, anti-TNF and thiopurine combination therapy may lead to higher fistula healing response and closure rate compared to monotherapy. This is an important information. Not only does it increase the immunogenicity, because thiopurine in itself also has a fistula closure efficacy, possibly the combination will be working better. And of course, if things don't work, then you should just be aware.
Snija, what is the other advantage of adding thiopurine to an anti-TNF agent?
I think I gave away the answer, but we should mention it again.
What are the advantages?
It will decrease the immunogenicity and decrease the antibody response.
Okay.
Hello, sir.
So these are the two advantages, of course, are that thiopurine by itself has got an efficacy as far as the fistula closure is concerned. And second is it decreases the immunogenicity and the instance of antibody formation, and thereby increases the efficacy of the anti-TNF. Okay, carry on, Rupa. I think we've come. Varghese, how much more time do we have?
I think we've crossed the time limit, so we will just go very quickly. So monitoring. Yes. So we need to monitor. So this is summary for everyone. Clinically look. Go for imaging with MRI, examination under anesthesia as necessary. Cetons, again, should be comfortable, loose, non-cutting cetons. This is something we should remember and tell our surgical colleagues. Short whiskers, otherwise the patient will curse you for the pain. Monitor luminal disease, endoscopy and imaging. Never ever in your exams mention only drug therapy. Mention it has to be a combination therapy. There is a significantly higher response rate if the surgical and medical management have worked together. Monitor drug levels and optimize therapy. Remember, once there is fistulizing Crohn's disease, the aim should be early closure. The longer the fistula stays, then the complete healing rates continue to get lesser. So what is different about rectovaginal fistulas? I mean, what are few things that you should remember about rectovaginal fistulas? Anything in particular?
Rectovaginal fistulas are more with as a complication of birth injury. And
no, I mean with Crohn's.
In Crohn's disease, it's a complex fistula.
Yes, correct.
And, in such cases, we have to do a multidisciplinary approach. with a surgical team and medical management.
So what you should remember is that it is anti-TNFs do not work as well as with perianal fistulas. Okay, depends on the size of the tract. MRI may miss it. So if the patient is telling that she's passing something through the vagina, or if there is, you have to mark the words for that, because even with MRI, the tracts sometimes are not visible, and surgical advice should be early. Surgical gynecological advice, because sometimes early surgery works better. So the little change in judgment. At the same time, whenever you see fistulizing Crohn's disease, remember, we sometimes miss vulval Crohn's disease, though it's rare, but it's a very severe disease. It is usually contiguous with rectal or perianal disease. Here, topical tacrolimus immunomodulators together with anti-TNFs work the best. Of course, again, anal carcinoma, rare, but we should not miss anything abnormal. It is always better to take a surgery. So key principles of treatment, and I think the learning points will be: perianal or rectal Crohn's predicts poor outcome. Patients have a lot to lose if therapy is not started promptly. There has to be close collaboration with the surgical colleagues, careful monitoring clinically, endoscopically, and with MRI. Escalate and de-escalate therapy according to response. That's a separate discussion altogether. Psychological support, educate patients. And then finally, something which Rohan had mentioned, role of defunctioning or a proctectomy or a diversion colostomy for severe perianal disease or severe rectovaginal disease should be considered. So the general algorithm for perianal Crohn's disease: if there's a stricture, go for dilatation; abscess, go to the surgeon. And then, as we discussed, you can just find this in Gut in 2014, a very nicely maintained algorithm, and when to do a diverting stoma, how to continue medications, when to do proctectomy. All this is clearly documented, depending on, as I mentioned, and once again repeating, endoscopic finding, MRI finding, as well as the EUA findings. So I'll just tell you, this is the patient which we are saying that is unable, finding it difficult to accept stoma. We have another patient. This patient, aged 14, was diagnosed early, treated with polymeric diet, corticosteroids, started as a thiopurine. 2019, developed a fistulizing disease, treated with antibiotics and thiopurine initially because they were not affordable. Later started infliximab. Ceton removed after week 6 and is now doing fine. So the timely intervention makes all the difference when you do a prompt diagnosis and rapid closure of the fistula. So we have learned this today, and I think that was the second case which we are not going to
I think yeah, we don't have time for the second case because there are some questions from the chat box which Rupa will just handle that. You did mention about the rectovaginal fistula. Sometimes you can get rectovesical fistula also, or colovesical fistula in Crohn's disease. These are also notorious for this, in the sense that they also don't respond so well to biologics. So very often you may have to resort to surgery before any other medical therapy is considered.
I think that is very important, that rectovesical surgeons should be called in first. We've had patients in whom surgery proved very helpful, and rectovesical, again, they are sometimes early ones are difficult to delineate, even with a MRI. So contrast MRI has to be used, and sometimes if the patient comes and tells you there are gas bubbles in the urine, that is classical, and I think we should go by that.
All residents must note that your history taking in a patient who's got, say, Crohn's disease should include all these things, because these are all indicators of complications of fistula.
Thank you, Dr. Ramesh.
So
and
it
Dr.
has
Rupa.
to be the recurrent urinary tract. Yeah.
Okay.
So I will end by telling that now we are all part of that IBD Emerging Nations Consortium. Here, for all residents, we are putting up IBD journal scan, a difficult case discussion forum, latest news, IBD news across the globe, latest papers, and there is personalized IBD registry. We also conduct the IBD masterclass every second Friday. Next is on 13th of August. I would like to see all of you becoming members immediately. Membership is free and details will be sent to your mails so that you can know more about IBD. Dr. G.N. Ramesh and all of us, Dr. Jayanti, are part of this initiative.
They are getting the information through this WhatsApp group also.
Yes.
Okay, then I think we come to the end. It is back to you, Dr. Varghese, for the final closing remarks. Thank you very much to all.
Thank you very much. It was a wonderful discussion, and I also learned a lot because very experienced persons are telling. Even though I also treat perianal Crohn's and all, but maybe once in a while. But to hear from a person who treats a lot of cases and that too complicated is something great. And both of you have done a great job. And before I close, Dr. Rupa, can the residents log into the IBD ENC website and then request for membership? What exactly is the method?
They just have to log into the website, give their name and email ID, and our secretariat will get back to them. They can become members. Yes.
So I request all the residents to become members because there are very frequent academic activity. Lot of activities are there in the IBDN group. So I request Dr. Sojan Jot, the office bearer of ISGK, to say the formal vote of thanks. Dr. Sojan, are you there? Is not there. So I formally thank Dr. Rupa and Dr. G.N. Ramesh for having done such a wonderful job. You have gone through such difficult cases and explained it so well, and I am sure the residents will be extremely thankful to you forever. Thank you very much. And thank all the residents who actively participated, actively listened, and all other faculty who also attended the session. Thank you very much. And Eid greetings to all my brothers and sisters having Eid.
Thank you, and good night, everybody.
We look forward to more such sessions with you, Dr. Rupa.
Thank you so much.
There are other things also. I think you have a regular IBD clinic also, IBD teaching session also. Second Friday?
Yes, second Friday of every month. So 13th August is the next one. And that is on small molecules and biologics.
Okay.
So, yes. It would be wonderful if you could join, Dr. Varghese.
Sure, we will all join, and I will also send a message across to all the residents through WhatsApp group PG forum. Okay.
Sure. Thank you, Dr. Varghese.
Okay. Bye. Good night.
Good night.
Okay then.
Right.
Rupa, thank you very much. Varghese, thank you very much.
Thank you. Thank you, Dr. Jayanti.
Jayanti ma'am, we didn't hear anything from you today.
So Charles Bernstein has agreed for Dr. Ramesh. Just Dr. Ramesh and Dr. Jayanti are there. These are the post moderators and the key people for the masterclass. Oh. So Dr. Charles Bernstein has agreed to give the talk on small molecules, and Dr. Ajit Sood is going to moderate the panel discussion on how to position tofacitinib. So that is the.
What time is it?
6:30.
Okay. I will inform. I will inform everyone.
It's early.
Okay.
6:30 to 8. Yes.
Okay. Thank you once again.
Thank you.
Good night to all of you.
Bye. You look like a minister, VT.
Minister. Namaste.
Good night.
Namaskaralu.
Bye.
Namaskaralu.
Bengali. Bye. Good night.
Okay.
Okay, bye. Good night.
Good night.